Hello, everyone. This is Michele Craig with Community Catalyst. Welcome to the webinar, Working with Hospitals on Community Benefit, Linkages, and Potential Opportunities. We welcome you to the webinar, and we're thankful that you're participating. We're going to be going a little bit through the agenda after we talk a little bit about the goals of this call. We are conducting this webinar to really broaden the conversation about hospital community benefit planning into the anchor institution arena and identify how the community health needs assessment process with community engagement can be instrumental to making this shift happen. We're also hoping for those of you who have experience in economic development to help us bridge the differences between community benefit agreements and community benefits with nonprofit hospitals. As an overview of the agenda, we're going to start with some PowerPoint presentations from both myself and Dave Zuckerman, and that will last through about the first 30 minutes of this call. Then we'll hear from our 3 guest speakers, 1 from the Community Health Network and 2 from the Northwest Bronx Coalition, and they'll be moderated through a question and answer session, and that will last about 30 minutes. And then finally, we'll try to answer the questions that you hopefully will be posing through the chat box, as well as some of the questions we got in the pre-survey, as time allows at the end of our call, with the goal of ending no later than 4 p.m. By way of introduction, my name again is Michele Craig, and I joined Community Catalyst in 2013 as the Outreach and Training Coordinator with the Hospital Accountability Project. And I currently provide and coordinate a broad range of technical assistance to our state and local consumer organizations through cutting-edge community engagement and training programs, such as community organizing, coalition building, and action implementation. I also serve as a liaison to hospital and public health leaders, government agencies, and national organizations, and I've worked in adult education and training, strategic planning and program evaluation, as well as coalition building and community engagement around a diverse set of issues, including land use, transportation, health, and economic development. And also you'll be hearing after my presentation from Dave Zuckerman, who is from the Democracy Collaborative. He's a research associate, and he's been working there since 2012. He's also the author of Hospitals Building Healthier Communities, Embracing the Anchor Mission. As a researcher, his work primarily focuses on community development strategies that build wealth in low-income communities, with a specific focus on how hospitals and health systems can better support their surrounding communities. He's also assisted with multiple feasibility studies of anchor-led economic development projects, and also serves as a principal editor of the CommunityWealth.org newsletter. So I'm going to begin by going into our first PowerPoint, which is titled Working with Hospitals on Community Benefit. And so I'm going to start by talking about what community benefit is. So community benefit is what nonprofit hospitals are responsible for providing because of their tax exemption. And they're required to report that to the IRS and the Treasury Department through their IRS Form 990 Schedule H. Additionally, the 2010 ACA added new requirements for these tax-exempt hospitals, including financial assistance policies, reasonable billing and collections, ending overcharging, more reporting, and conducting community health needs assessments, as well as developing implementation strategies to address the needs that come up in those needs assessments. We also know that some of you are working in the economic development arena and that you're familiar with a term that sounds the same but has some differences: community benefit agreements, or CBAs. CBAs are contracts that are executed between community-based organizations and 1 or more developers, and they're intended to outline the developer's commitment to provide a range of benefits to the community to offset the potential impacts associated with the proposed development. CBAs are legally binding and are commonly incorporated into the city's developer agreements, and you'll hear more about that in Allison and Yorman's section of today. But a CBA is a contract that's signed by community groups and a real estate developer that requires the developer to provide specific amenities and or mitigations to the local community or neighborhood. In exchange, the community groups agree to publicly support the project or at least not oppose it. Often the CBA relies heavily upon the formation of a multi-issue, broad-based community coalition, including community, environmental, faith-based, and labor organizations. And again, you'll hear more about those when Allison and Norman talk later in the call. So what are some guiding principles for community benefit? Community Catalyst defines community benefit as unreimbursed or partially reimbursed goods, services, and resources that are provided by healthcare institutions in response to needs and concerns identified by the community, especially by people who are traditionally underserved. And in many ways, we view these last 2 points as critical to successful community benefit planning. Focusing on this last bullet, it's critical to note that we view community benefit as an opportunity to invest in building leadership and empowerment for local communities, with a spectrum of involvement and empowerment of community members. There are certain principles that hospital staff and others can use to ensure that community involvement is meaningful, more than checking off a box or seeking a rubber-stamped approval. In fact, the ACA requires hospitals to take into account community input. We ask them to go further. The longest lasting partnerships that we've seen, the ones that achieve the most, really engage and empower community partners. And there's a difference in these words with engaging and empowering. So some examples. Now I can hear some feedback. If there's someone who has not muted their phone, please do that at this time. Okay. So some examples of community benefits that some may be familiar with and others may not are financial assistance to low and moderate income patients or patients who are medically indigent, programs that operate at a loss like a neonatal or burn unit. They can also include transportation services to outpatient programs. There are also programs to prevent ER visits and hospital admissions through childhood asthma. Green space for community exercise and enjoyment, things like street lights, pushing the city to add patrols to increasing safety, as well as targeted programs to address health disparities. Other things like workforce development and youth training can also be included under community benefits. There has been an evolution in community benefit. Oops, how can I go back? As you can see from this chart, traditionally the focus, as we know, for community benefit has been on creating access to care through making it more affordable, primarily through charity care and financial assistance programs. But today we know there's a greater focus on promoting health and reducing illness and injury and addressing social determinants of health, which are what are indicated in this chart. There's still going to be a need for emergency room access and affordable health care. That isn't going to go away even with the Affordable Care Act and coverage expansions. But we're asking hospitals and other healthcare providers to think about some of these upstream components that are on the right side of your screen that include things like education, employment, income, and community safety. Community Catalyst is also working with 3 pilot sites. The Northwest Bronx Coalition is one of them. We have 2 others in Oregon and Minnesota who are incorporating some of these social determinants into their advocacy work with their own local hospitals in an effort to ensure hospitals are taking into account other aspects of community health more than just merely access to care. And some of these include economic development strategies. And through that work, we're building the capacity of the lead community-based organization and then conducting a training with participants from low-income and immigrant communities, as well as communities of color, to get involved in the hospital community benefit process in their areas. So stay tuned for more information about that as we continue to talk about this issue. Oops, something's happening with our PowerPoint. So we should be on a slide that says what counts as community benefit. And that's the next slide. There we go. So a lot of things can be part of a hospital's community benefit program. And here's a list of automatically reportable items on that Schedule H form that I talked about. What's a community health improvement service up in the left-hand corner? It's meant to meet a demonstrated community need, but it also has to meet a program objective. What also needs to be considered as hospitals are thinking about community benefit is community building. So things such as physical improvements to housing that help reduce the harm and health of residents, as well as development or maintenance of parks and playgrounds. Things like economic development, community supports, and leadership development also count as community benefit. Okay, so what are hospitals actually doing? And there was a recent study that came out on the fiscal year 2009 where hospitals in that study spent about 7.5% of their operating expenses on community benefit, with more than 85% of those expenditures on charity care or access. And 5% of the operating expenses were spent on those community health improvements like safety and economic development. The rest was spent on education, research, and community group contributions. So we know that hospitals are starting to think about some of these upstream determinants, but mostly they were thinking back in 2009 about access. So the new ACA rules fit into this process. They require hospitals to assess community health needs and adopt and implementation strategies by requiring input from public health, community members, and other representatives of the community. This provides an additional tool for advocates to use to weigh in on health equity, access, and public health issues impacting the community through the Community Health Needs Assessment, which also requires board approval, which is a new rule under ACA. This chart is a very busy chart, but it outlines sort of the process of how a hospital deals with their community benefit process. And so it starts with defining the community or the geographic area that the hospital serves, then collecting the data and interpreting it to determine priorities that they're going to address in the community that they serve, selecting which needs they want to address and which they will not, and why, and then making the report of that process readily available to the public to give feedback as they think about the priorities that they're going to address and develop implementation strategies to address. So when we think about evaluating this process, what are some things you should be thinking about? Who was involved in the assessment and who was left out? Who should have been included? Who should be involved in the implementation strategies that the hospital develops? How the needs were prioritized? What and how the data were gathered, analyzed, and presented to the community, and whether there were missing pieces or relationships that the advocates can bring to the table that might be crucial to the success of the hospital addressing the community's needs. So that's the end of my presentation, and now we're going to move on to Dave Zuckerman from the Democracy Collaborative to talk about anchor institutions.
Hi everyone, thanks for joining us today on this webinar. My name is Dave Zuckerman, as Michele said, and so nice to introduce me earlier. The Democracy Collaborative is a research center based at the University of Maryland, very much focused on innovative strategies for community-based economic development. Our website, which you can see featured on the screen before you, community-wealth.org, serves as a clearinghouse for information regarding these strategies. And in a little bit, I'll talk a little bit more about our philosophy and the strategies we promote. But just as a little bit of ways of background for what we do, we are very much a research to practice organization. Our work includes field building through on-the-ground work with foundations and other institutions, as well as activities like webinars and such. Over the last year, we have released several reports with regards to how health systems can have a greater role in economic development. The one featured here on the screen examines leading examples, including 6 in-depth case studies, and documents the variety of strategies being used. And some of these strategies are from local hiring and purchasing, local purchasing, to affordable housing, to investing the hospital endowment locally, nonprofits, or health clinics through low-interest loans. And this is just a few examples of different ways that they're getting involved. Many times these are through partnerships with other organizations, which is all to the better. And some of these efforts resulted from discovering that these strategies were the best way to tackle local needs that were very much impacting community health. And in those cases, what occurred was very much connected to the principle of community benefit that Michele just elaborated on, even if explicitly community benefit activities still focused on charity care. However, in many cases, there were entirely other reasons that prompted a hospital or health system to become more involved in the realm of economic development. Crime, employee needs, institution perception, local government pressure, all of which are legitimate reasons to do so, but from my perspective, and I think what today's discussion will touch on, is how do we utilize community benefit, an obligation for all nonprofit hospitals, as a lever for thinking more strategically about how a health system can activate its resources to alleviate those upstream determinants that are so critical to a hospital's ability to achieve its stated mission of actually promoting health. And if we revisit the question of why we are talking about economic development rather than other types of community health intervention, it is because of the role of social determinants of health. Michele also discussed this earlier. What you see here is the same information, just in a different shape, but it's worth spending another moment on and reiterating the fact that only 20% of one's total health, whether it's life expectancy or health status, is connected to the access and quality of the health care we receive. The other 80% occurs outside hospital walls, influenced by social and economic determinants along with healthy behaviors. And when we think about it, our healthy behaviors are very much a product of our social and economic conditions. So in order to successfully move the needle, we need to continue to move away from treating symptoms and think about treating root causes. And I think it's a little bit more sobering when you think about the other two statistics on this slide on the left, that 1 in 5 children or 1 in 5 Americans under 18 live in poverty. And what happens, and as we all know, what happens in childhood has a dramatic influence on the habits and your health conditions throughout much of your life. And that 33% of Americans, so 1 in 3 Americans, are working poor, which means that they earn less than 200% of the poverty line. And these Americans are essentially one accident away from falling into poverty. They have no savings and no safety net, and often credit card debt and healthcare debt is a good portion of that credit card debt. And when you concentrate the social determinants, you begin to see the impact in very real terms. These graphs illustrate the changes in life expectancy between small distances in just 2 of our cities, New Orleans on your left, Metro DC on your right. And in just a short distance, you can see a drop of 25 years in life expectancy based on where you might have grown up and the opportunities where you grew up provided you, in the case of New Orleans. Metro DC, where I live in Prince George's County, so that's the upper right-hand corner of that graph. The difference is less extreme, but still dramatic. I mean, we're talking about 8 years in difference in life expectancy just by traveling a few miles along the metro lines, which is what you see depicted on that graph there. That's the metro line here in DC. And when you see these maps, the oft used phrase that your zip code is a better determinant of your overall health and life expectancy than your genetic code becomes much more real. So we know this, place and poverty matter, but how does this translate into community health needs assessments and more broadly community benefit activities that a hospital undertakes? And I've had the opportunity to review a couple of these needs assessments that are beginning to come out, completed by various hospitals, and it's very much an evolving process as the final regulations are ironed out. And this is the first round for many hospitals. Some states have had requirements previously, but for many health systems, this is the first round and it's specific IRS regulations. So here you see a couple of graphs from one assessment in particular that I think is a great example of the possibility of these assessments to kind of advance beyond the idea of just focusing on, say, obesity or diabetes or mental health, all are critically important issues, but also begin to connect them to the underlying root causes that might have helped contribute to some of them. And this, in particular, this assessment is from Hartford, Connecticut, and it was led very much by the health department, but all 4 hospitals have signed on. And what you see on your left is a poverty score by neighborhood, and then on your right, the diabetes score by neighborhood, and the very much the correlation. And they make the correlation themselves through a lot of connecting the these symptoms, diabetes, obesity, etc., to stuff as poverty, housing options, etc., and make the connection that education and economic security are critically important. And yes, we haven't seen the implementation plan on how they're going to address some of these, but it clearly demonstrates that poor housing, economic conditions, educational attainment are what you need to address if you're going to make a dent in some of the health conditions that result as a consequence of underlying factors. So one last slide on this, and this is the Catholic Health Association and Healthcare Without Harm released a report earlier this year making similar connections and pointing out similar opportunities existing in the law to count activities addressing upstream social determinants as community benefit. As you can see, the report was very much based on environmental determinants, but the same principles apply. So it is very much one thing to note the needs. It is entirely another to actually work to implement a strategy that comprehensively addresses those needs, especially when we're talking about issues of economic security. At the Democracy Collaborative, we come to term the specific strategies for community and economic development that we promote, community wealth building. And at its core, community wealth building seeks to build on and leverage traditional community assets in combination with outside resources, while trying to ensure that the traditional population retains control of those assets and is not ultimately displaced. We seek strategies that emphasize the democratization of wealth, focus on place and local economies, promote broader ownership of capital, anchor jobs locally, and stops the leakages of dollars from our communities while supporting individual and family wealth building. Anchor institutions, which is a prime topic of today's conversation, is just one community asset that we suggest can be key participants in this process of building community wealth. So what are anchor institutions? Well, they can be hospitals, they can be universities, they can be local governments, they can be municipal utilities in some cases, nonprofit cultural institutions in others, faith-based institutions in others also. And so what do these all have in common? Well, it's very much the idea of, got ahead of myself there, it's the idea of sticky capital, and ever a very mobile corporate capital. These institutions in general, not in every situation, buck that trend. In many communities, you will find that hospitals and universities are the largest private, although nonprofit, employers as traditional capital has migrated away, whether thrived, and I put that in quotes, by another municipality. And perhaps if we think of Boeing as an example of this, it's been in the news on this, and Seattle was forced to, or the state was forced to offer nearly $9 billion in tax incentives to keep them from simply picking up and leaving, or whether these corporations have gone abroad because of labor costs or other reasons. So that means that the university or your hospital, and today we're talking about hospitals, is often more than just a hospital. It is a critical piece to the remaining economic fabric of the community in which it resides. And if we zoom out once again, we can really see the economic dimension of this sector. And I point out expenditures and endowments on this chart because these are resources that could perhaps be used in different ways to amplify traditional community benefit activities that often have to be a net loss or at cost for the institution. So as a critical economic actor unlikely to move, a health system has a vested interest in having the surrounding area thrive for its own bottom line. A thriving community also tends to be a healthier one. So you can see where I'm going with this a little bit. If we consciously think about creating a thriving and healthier surrounding community by improving the circumstances of the current residents rather than trying to attract new ones, we both advance the long-term interests of the health system while actually improving overall health in a way that tackles root causes. And so it's about rethinking how health systems do business and how they think about their charitable, and I would put that in quotes, activities. Earlier this year, the Democracy Collaborative, along with MIT, released a separate case study specifically on university hospitals in Cleveland. This is a quote by their CEO. their vision regarding their Vision 2010 initiative, which was about driving purchasing locally and to minority and women-owned businesses. It was massively successful, and it was very much groundbreaking in its scope. But it wasn't done within the lens of community benefit as we talk here today. Perhaps what happened there reflects more about the targets and desired goals of community benefit agreements, which Michele clarified earlier, and which is not what we're necessarily talking about, but which we'll hear a little bit from Allison later on. Although in this example, what UH did was entirely voluntarily and catalyzed by the health system itself. And it's important to note because the language that Tom Zenti uses here is very much one that connects to the idea of community benefit, and it's about going about it in a different way. And so I'm going to end with a slide from a piece that we recently released called the Anchor Dashboard, which could be a presentation in itself. I'll only spend a minute or two talking about it. But in short, we interviewed more than 75 people representing anchors, foundations, and community organizations to develop 12 indicator areas that anchors, including hospitals, can track outcomes in. And these indicators are specifically geared to reflect measurements that show progress for low and moderate income families and communities. It is to develop a framework to begin a conversation about how we can measure not an impossible number of metrics, but those metrics that capture meaningful progress for the most vulnerable populations. So if you begin to accept the notion about what we're talking here today, and of course I hope you do, that focusing on economic development is critical to moving the needle on overall health in the community and to the long-term success of the institution itself. And in some senses, I think it kind of begins to merge the worlds of community development, public health, and healthcare into one. Community benefit becomes more than just a program area within an institution. It becomes a guiding philosophy that should filter into every aspect of hospital operations, including the business practices. And we here at the Democracy Collaborative have come to call that the anchor mission. And so more information can be learned at the website provided below, and people are welcome to follow me via the email address you see on the screen or in the questions section later on. I'm going to end my presentation there now and turn it back over to Michele, who will introduce our next speakers, who will talk a little bit about their experiences on the ground.
Great. Thanks so much, Dave. And again, to remind you, if you have not posed a question and you do have a question, make sure that you put that in the chat box so we can consider that for our question and answer period at the end of the call. And again, as Dave mentioned, we're going to transition into some case studies, and we're going to do this in a moderated question format, so you won't be seeing a PowerPoint, but you'll be seeing the faces of the three people I'm going to introduce right now, starting with Dan Hodgkins, who's the Vice President of Community Benefit for the Community Health Network in Indianapolis. The community benefit programs that they do include health screenings, assessments and interventions, school-based health centers, and the Parish Nursing and Health Ministries program. Through Dan's leadership, community benefit has expanded to include some non-traditional partnerships, such as community garden initiatives, local healthy foods, exercise initiatives, and support of neighborhood growth organizations. Dan's been active on several boards, including the Domestic Violence Network of Greater Indianapolis and the Jane Pauley Community Health Center. As a healthcare professional for over 25 years, Dan is passionate about healthcare reform and increasing access for all for primary care. In line with his passion, Dan has provided consultation services to the National Health Service Corps, which places primary care practitioners in underserved areas of the country. And Dan has championed the Wellness Opportunity Zone as a concept and intervention for the overall health improvement of a community. And then we have Allison Manuel, who's been an institutional organizer with the Northwest Bronx Community and Clergy Coalition for the past 4 years. During this time, she's worked with an array of schools, churches, and community-based organizations to train and organize their members to run strategic campaigns to improve schools, housing, and community-based development. She coordinates the organization's economic democracy work to enact a comprehensive organizational platform for economic development that generate shared wealth and democratic decision-making power for Bronx residents. She also coordinates the organization's Community Leadership Academy, which provides ongoing training in political education and organizing skills to prepare the next generation of community leaders to enact change in the community and carry forward the vision and mission of the organization. She lives in the Norwood community of the Bronx, where she's also a leader of the worship team of New Day Church. And finally is Yorman Nunes. He's interested in playing a role in lifting people out of poverty through redesigning the economic system that is our economy. His commitment to designing systems to address the causes of poverty emerged out of his work as a community organizer with the Northwest Bronx Community and Clergy Coalition, where he organized young people around issues of sustainable economic development, education, and voter education. It was during this time that Yorman co-founded the Urban Youth Collaborative, a citywide youth organization working on education reform. He moved on from the Northwest Bronx Coalition to lead a career in electoral organizing, where he's managed many political campaigns. He currently coordinates the Bronx Cooperative Development Initiative, which is a local effort in the Bronx that seeks to leverage local assets to drive economic development strategies targeted at building wealth and ownership among low-income residents. Yorman is a lifetime resident of the Bronx, and he's taught both community organizing and spoken word at the high school level. Additionally, he's a fellow at the Massachusetts Institute of Technology. And you can see their pictures up on the screen. And so now we're going to start a moderated discussion with the three panelists. So I'm going to start by asking Dan, what was the process for the Community Benefit Office for deciding upon the work that you focused on?
Can you hear me?
Yes.
Terrific. Well, thanks. First of all, I can't thank you enough for having me be a part of this discussion. And to start off with, I don't think at any point in our discussions here should anybody come off as an expert in the sense that this is such a whole new field that there really isn't any right or wrong way to do anything. And though we have looked at some regulations, if you will, and some definitions, if you really catch the spirit of what we're talking about, it happens in the community. And I think, as Allison and Yorman will attest, when it happens in the community, it can get pretty messy. So this is not for the faint of heart or for those who want to be able to typically go in, do something, get out, and call an outcome done. This is for long-term sustainability. So that's the first point I want to make as far as, you know, what works in Indianapolis may not work in another city. There are best practices, but that community has such a strong influence in any outcome that you really can't say this is the way to do it. To that point then, when you talk about how did we, you know, focus or decide for the focus that we have, I really think it's a journey. And I'm not sure, you know, as some famous person said, you know, to arrive, to travel hopefully is better than to arrive. So let's just talk about this being a traveling hopefully kind of venture. And first of all, in Indianapolis or Indiana at IU University, Indiana University, there was a woman who won the economic prize, Nobel Prize in 2009 named Eleanor Ostrom. And I raised that because Eleanor was the first person in 2009 to suggest that what she called the commons, which is air, water, and I would propose health is another one of those things that a community shares, can be managed by the community. Prior to that, most economic models saw that air, water, lakes needed to be either privately owned or managed by government. So it's only been 2009 that we've had this model of economic stability given to us for saying that the community can manage its own commons. So I believe in that, and quite frankly, our hospital, which was developed in 1954 by a nickel and dime campaign where the neighborhood went door to door to churches, schools, and businesses, collected money to build a hospital that they wanted to serve the East Side. That kind of community development and that kind of community support brought us to be. Today, we're the second largest healthcare organization in the state of Indiana, and I hope that our community benefit priorities have really been set in 1954. So when we prioritize, I'm going to say that we prioritize with the community's direction. And some of that work I'll talk a little bit about, but quite frankly, I think at this point, it'd be interesting to hear if Allison and Yorman share some of the same ideas that this work can be messy.
So Allison, how did the Northwest Bronx Coalition organize around this vision of economic development? What was the spark that led you to do this work? Are you there, Allison? Oh, yes. Allison?
Can you hear me? Great.
Yeah.
Hi. Sure. So the spark for this vision really can be found in a nearly 2-decade-long campaign to redevelop the Kingsbridge Armory, which is the largest armory of its kind in the world, located in the Bronx. That has the community has really waged, like I said, over the past 2 decades to redevelop this asset, this really historic landmark, in a way that would benefit the community, in a way that would meet tremendous needs, and also realize the visions of the people of the Northwest Bronx for what that building could be as an asset. And that campaign recently has kind of nearly culminated in the signing of a community benefits agreement that has some really kind of groundbreaking tenets in it around local hiring and living wage jobs and local procurement of goods and services and a community designed community space and a really comprehensive green action plan, all of which are kind of are seeds that have been sown that are indicative of the kind of paradigm shift that we're seeking in economic development in low-income communities of color like ours. And so we're really excited about that and how far we've come. In fact, just this morning I came back from a press conference on the steps of City Hall, where we are calling on the City Council to approve the plan, which is the final phase and the process to bring this to fruition. However, the previous chapter of that fight looked a little different. I came into the organization in 2009, right at sort of like the tipping point in a struggle with a previous developer of that building, named the Related Companies, who had wanted to redevelop it in a way that would only offer part-time minimum wage jobs with no negotiation with the community, no commitment to local hiring, no consideration for impact to the environment. And so at that time, the coalition had really built up a broad base of faith-based and institutions and labor institutions and community-based organizations and elected officials that really decided that this was a time to draw a line in the sand and to say no to that kind of development, because we understood that historically economic development initiatives in the Bronx are focused on predominantly low-wage job creation with little potential for local residents to really build their assets, and it even at a moment in 2009 where jobs were in such dire need, we felt that in order to really forward, like I said, a paradigm shift of how development is done in low-income communities of color, that this, it simply couldn't be tolerated. So we, made history when at that time we organized the city council to vote down this project that was heavily backed by the Bloomberg administration. But in the process, we found that as kind of, political pressure became more and more intense, our alliance really fractured, and labor and community and youth and parents, folks were, really kind of fractured at the end, in spite of the sort of bittersweet victory of stopping that bad development. But that was something that really kind of troubled the organizer of the campaign at the time, Nick Uvian, and the community leaders that were engaged, of how do we build deeper relationships that kind of stick together in the long haul and can move towards a proactive vision of development, not just for a building, but for our borough. And so Nick Uvian actually left our organization and went to MIT, where he studied urban planning, and at that time really devoted himself to looking at these sort of alternative economic models that have taken root in different parts of the country and the world, such as the Evergreen Cooperatives in Ohio, Cleveland, Ohio, and the Mondragon Cooperatives in the Basque region of Spain, that really kind of focus on these principles of wealth and ownership in the hands of residents. And out of his time of reflection and research, there he and Jorman, who should be hopefully joining us shortly, who was formerly an organizer and a board member and a leader from the coalition, really were the initial architects of what has grown into the Bronx Cooperative Development Initiative, which at its heart is really dedicated to building a sort of a much deeper and wider and more comprehensive development agenda, and building the power, pulling together the sort of powerful alliance of stakeholders in our borough, and the technical expertise that would be needed to do that, and really centering that on a vision of shared wealth and ownership. And I think that vision was really distilled through a process that they went through in 2011 of holding lots of house meetings with members of other community-based organizations to try to talk about what have been the consistent roadblocks in achieving breakthrough in our struggles around economic development. And a lot of the, kind of the themes that really kept coming up were this recognition that a borough like the Bronx and a city like the Bronx is a hub of assets and wealth generation. It's just that we struggle that our economy has been developed in such a way that wealth is constantly leaking outside of the borough. And so how can we pursue development strategies over the long haul and ownership models that really root and really recycle that wealth that's generated from the economic activity in the borough. So naturally, the sort of import replacement model, they're looking at anchor institutions, and how to unpack the goods and the services that they procure, and rather than that, that going to outside contractors outside the borough, how can we support an infrastructure of worker-owned cooperatives, especially, that can really localize that supply chain right here in the borough. And so to do that, we've been pulling together both a table of community partners that includes our organization, the Northwest Bronx, and The Point, Mothers on the Move, Green Worker Cooperatives, Consortium for Worker Education, and 1199 SEIU, to make sure that we have that sort of broad broad base of community stakeholders that are on the ground in the different neighborhoods of the borough, as well as building an anchor table, anchor institutions. So the four largest employers in the borough, Montefiore Medical Center, Fordham University, the Bronx Zoo, Botanical Gardens, and other institutions of higher learning like Hostos Community College. And then kind of bring those back to those with some really key technical assistance institutions like MIT's CoLab and CommonWise Business Solutions, a nonprofit consulting firm led by Jeffrey Hollander, so that we can really, one, build the infrastructure, but also incubate policies and projects and organizing campaigns and a political education program that is all working together to, like I said, build this sort of development agenda for our borough that is deeper and wider and more comprehensive than what we were first striving for at the Kingsbridge Armory. Because while I think that achievement of a community benefits agreement is a historic model for folks across the country, we know that we're not going to get the kind of systems change that we seek to address intergenerational poverty by just negotiating a community benefits agreement every 20 years in a project-by-project basis. So.
Okay, great, thanks. And so, Dan, as Allison listed off some of those partners in her anchor institutions like Montefiore Medical Center, what's your perspective as a hospital administrator about the internal and external challenges that might be faced by hospitals from the hospital side in adopting some of these anchor institution strategies? Did you have to overcome any of these barriers?
And Allison will attest, I'm sure, with her work with Montefiore, that absolutely, both internal and external. I think that we banter about some words like shared wealth, anchor institution, in a way that it seems informative. However, I think for the average hospital administrator, especially in today's world of trying to negotiate the ACA, that is so far afield from the kind of language that they're used to. And so just becoming familiar with that kind of nomenclature, and again, to say this is such a new field that there's not a whole lot of nomenclature that's shared, that, as you guys talked about shared wealth and anchor institution, one term that we're using is health district, but in the anchor institution nomenclature, that means something totally different than how we may be using it. So I think once we sort of speak in one voice, things will be clear and models will come out of it. But for now, the models that we have are the old business models. And because community benefit, for the most part, has come out of marketing departments, that oftentimes what you see as far as community benefit strategies are linked to some kind of marketing event, and sponsorship. And that's the historical look at community benefit. More recently, with the IRS 990, financial departments have become more intimately involved, because it's really taken a whole new level of bookkeeping, or accounting that hospitals didn't even have access to prior to the 990 and the ACA. So one thing that I want to say is, it's like this is a learning process for everybody. So this kind of discourse back and forth is really important, so I can understand what Allison and Yorman are doing with their hospital. They can understand what I'm doing with mine, and maybe there can be some great, cross-learning, if you will, or learning from each other's experience, because this is all new. I guess the biggest shift is that marketing, that this is not about sponsoring a run, because so many hospitals do those kind of activities, and in the old days we would call that community benefit. Today, community benefit are things like we set up an individual savings account for folks in a high poverty area. We were pretty proud of ourselves However, the financial literacy in that community and the individual savings account matched $1 savings with 4, so that at the end the person who saved $1 would have 5 to spend on education, buying their first home, or developing a small business. And the reality was that was our mental model for how maybe we could help that community. That was not the level of financial literacy that that community had, and we needed to take time out to say, what do you need in that sense, not tell them what we need. And consequently, that's kind of what I mean about the messy part. And Allison, I'm very, very impressed with what your community has done as far as bringing these disparate people together, because there is all sorts of culture and language and mental models that they all come with, and it's really hard to get them all, as we like to say, singing from the same hymnal. So wandering a little bit here, but internally it's language, it's mental models, and externally it's language and mental models that for me seem to be the biggest barriers to creating. So having a common language, a common understanding of what we're doing is going to take some time and take some work, but it gets you further down the road than if you just go in and assume that this is going to be best for everybody. Thank you.
Great. Oh, great. So I'm going to just move us ahead a little bit. And Dan, I wanted to come back to maybe talking a little more about 1 or 2 concrete activities that might connect the dots between anchor institutions and community benefit work that's specially related to economic development. So you talked about the individual savings accounts, but are there other economic development work that you've incorporated into your community benefit work at the hospital?
You know, yes. The short answer is yes. And again, I want to talk about models. So when we think about what an economic development program is, even like the term anchor institution, if the brain is a muscle, then it's a big stretch for a hospital to see themselves as an anchor institution or anything else than seeing their role of delivering health care within the
Welcome to GoToWebinar, Web Events Made Easy.
Poverty. Hospitals were at first dealing with folks who were ill and couldn't afford someone to come to the home. And it's almost the very exact opposite today, yet the model of delivery hasn't changed too much. So
Welcome to GoToWebinar, Web Events Made Easy.
Health program in the sense that healthcare needs to be delivered in the community, and we know that from our community benefit needs assessment, community health needs assessment, and so let's call that access. So when we go to the schools where we know children need access to health care, we really know that we're delivering them a model of care that, for the most part, can be preventative and can also manage chronic disease. However, another byproduct and outcome of that is that there's more seat time for that student. For example, someone who's developed pink eye can get a prescription antibiotic for that particular diagnosis that very day and be sent back to the classroom. That means that child has not missed a day of school. Now, not missing a day of school means that they're more likely to learn, and more likely to learn means that they're more likely to graduate. When they graduate, they're going to be employed, and that's a taxpayer. And in order for us to really develop the economy and develop health, that leads to jobs and employment and those kind of things. So if you'll just look at us delivering health care in schools as a medical model, you're going to miss the whole longer-term approach, looking down the road, that our hope is that whatever our intervention is, we've allowed that child to graduate with a degree that, had they not been graduated, would be less of a taxpayer. So that's the kind of concrete example I can give you, and the logic that goes behind why we're doing what we're doing. And it's a longer-term view and one that incorporates other folks' mental model instead of our own. Does that help?
That's great. And so, Allison, kind of in response to that, from a coalition or a community-based organization perspective, who's for a group who might be doing similar work to engaging anchor institutions, so what might be some recommendations you would have?
I think first of all, we really understood intimately through our previous campaigns that a multi-stakeholder approach is really essential for us to forward a deeper and more meaningful economic agenda. That we need to be comfortable with building partnerships with people that we aren't used to even thinking of working with, and kind of like identify our self-interests, our shared interests on a deeper level. I think, you know, it's easy as a community-based organization in the Northwest Bronx to not look outside of the Northwest Bronx, or even just to work collaboratively with other community-based organizations in the Bronx can just be challenging. But really kind of going over that hurdle to build those deeper relationships, to see how our local economies kind of all fit together as a region. And then also with unions and with anchor institutions. I think, you know, the hospital, as we're starting to explore a relationship with a nonprofit hospital in our areas, those have, and other anchor institutions, those, you know, historically we've either had no real relationship with them, or we've approached them as a target of an organizing campaign. You know, for nonprofit hospitals, if services are shutting down, or you know, discrimination based on insurance, or there's just been sort of like a transactional sort of relationship. So really kind of coming to the table to think about how can we shift our approaches to one another, to build a deeper relationship and understand one another's stake in addressing intergenerational poverty in our community, has been really essential. And I also think that capacity building has been another crucial phase for us. We, as part of the Bronx Cooperative Development Initiative, piloted what we call an economic democracy training series, which was really geared at engaging our membership in deep sort of reflection and learning around you know, lifting the hood of our local economy and understanding it and how it works, you know, on a deeper level, and learning to kind of think about it almost from the vantage point of a developer or somebody coming from the business field, and to think about different approaches to problem solving in our community and relationship building, aside from sort of like the straight ahead direct action organizing campaigns. But, you know, this whole question of asset mapping, and rather than just thinking about what are all of the ever-present needs that are around us that we're you know, drowning in, what are the real assets that we have in our midst, and, you know, and seeing an institution like a hospital as an asset that we can really can engage with. So kind of that deep political education to shift the way that we go about problem solving and building relationships in our community has been important. But then also the phase that we're kind of in now is more like once we start developing strategies, you know, or economic development projects, then there's a whole other world of technical skills that we need to develop to execute those projects and strategies. So we're about to launch trainings with Community Catalyst on understanding the community health needs assessments of Montefiore Hospital and other nonprofit hospitals in our area, so that we can prepare ourselves to really come to the table and shape these assessments and be able to be a real stakeholder and a player in the projects and the initiatives that are implemented based on that.
Okay, well, thank you. That was actually very interesting in thinking about some of those ways to engage the anchors. So, Dan, when you think about the hospital perspective, how could those coalitions or community-based organizations approach a hospital system? So who should they be looking for, and how might they develop those partnerships with the right people at the hospital?
Thanks. And I think Allison gives great examples of how the hospital resources can be used. And really, Michele, when you started off the meeting in defining some of the community benefit law or the IRS regulations, the whole idea that there's a community health needs assessment that they are mandated to provide the community is one that is a terrific way for other organizations around that community to become involved. And what we've experienced is what compliance to that law requires is that you could, for example, do countywide data, and that would suffice. However, in Indiana, for example, what the county looks like on the north side and what it looks like on the east, west, and south side are totally different. So being able to use that data in a way that really targets the neighborhood, so looking at zip code or census tract data, really informs the community as to what particular issue they're looking at. And so there's plenty of socioeconomic data out there, but hospitals have some more data as far as diseases and how many admissions to their emergency room and how many folks are hospitalized for diabetes and how many kids show up to the emergency room for asthma. And let me just stop there to say that that particular data, asthma, can then be used to go to the schools, as I was pointing out, to help manage that chronic disease. However, what we find in a lot of our situations where the chronic asthma issues are rampant, there's also landlord-tenant issues because a lot of those kids are in rental houses or apartments and probably don't have the best filtering devices. And consequently, these folks have to exercise some sense of power over their landlords. And so you can see how one specific diagnosis can look and be sort of a surrogate for other issues in the community. Another huge surrogate is, for example, is urinary tract infections. And I know for most lay people to know that a urinary tract infection and how many hospitalizations are because of that doesn't mean a whole lot, but it's for the clinicians who work with older folks that typically if you're older, you get a urinary tract infection. What comes with that is some sort of psychosis or some forgetfulness or what some people would think even was they've gone crazy. The reality is that's the reaction to a urinary tract infection, and the point would be is that they need to get on antibiotics, yet what you might find in the community that these folks are being brought into housing or into senior living conditions, not because they have anything other than a urinary tract infection. So a lot of our data in the hospital can be surrogates for other issues in the community. I think just one other thing that I would say that, as far as who to connect to, I think the finance department and the CFOs can play a very, very important role, as well as marketing, which is, typically, or community relations is where some of the responsibility lies. But oftentimes those departments are also overwhelmed with requests for giving and those kind of things. So kind of a back door to all of this would be a CFO. And let me tell you what we did in our organization as an example. And this is a work in process, not necessarily anything that's put in place right now. But this fiscal year, we spent $84 million in charity care. And that's a huge increase from our previous years. But with the data that we were able to collect and with our community health needs assessment, we found out that represents 1,638 zip codes. And what was interesting about that is we only have 83 zip codes in our service area. So the reality was people were coming to our hospital for charity care because we really did have a more generous policy than most. The point I'm trying to make here is we looked at that data. We put then some other data on top of that, like median household income, folks who spent more than 30% on their rent, so their disposable income was probably pretty nil. And if someone's paying 30% of their rent on 30% of their income on rent, and they're a single parent, there's also probably not a whole lot of flexibility in the kind of money that they're going to be able to bring in the long run. My point just being then, what if we, instead of giving to everybody who came through our door, what if we were able to select zip codes that had all those indicators that we talked about, so those are the people in need, and instead of spending $84 million in a haphazard kind of shotgun approach, what if we looked at our 83 zip codes? What we did is we found 33 of those 83 zip codes that were high need, and we focused our charity care dollars exclusively on that, those zip codes. What does $84 million look like in 33 zip codes as opposed to 1,638? So with the finance department, we're working on that. We're trying to make sure that we're not going to violate any IRS regulation. And I got to say, the IRS is not prescriptive. They describe things, and we're not going to be audited. We're going to be reviewed. So there's a lot of misunderstanding out there in the community of what's possible, and having these kind of discussions and, working with community catalysts and, figuring out what is possible is pretty important. And then, the other thing is I just want to make sure that this is clear is that, when you talk about anchor institution, I want to make sure that we understand that that is a great nomenclature to use. I didn't mean that we haven't come to any particular nomenclature agreement, but this is one that's suggested and seems to me to fit the model that we're trying to get at in the discussion that we are having here, and one that Allison is also putting forward. Is that
great?
Help?
Oh, sorry. I didn't mean to
No, go ahead.
interrupt you. I just want to get us into the Q&A section because I think you've led us to a good place where we can start to address some of the questions that are seeming to come up basically around what you're talking about. So if you don't mind me interrupting, I'm sorry. I'm going to turn it over to Dave to start the Q&A.
All right, so we've been getting a few questions as the presentation has gone on, and also a few prior to the presentation began. So we've kind of merged questions to try and make them as broad as possible to allow people to address different points of them. And any questions you don't feel like we adequately addressed here today, we will definitely try and follow up with you privately afterwards. But for the first question, I'll actually direct it to Michele. How can local community-based organizations or advocates get involved in the local hospital's community benefit process, and what leverage can local groups use if the hospital thinks they can, do it all, and I put that in quotes, without a robust community engagement process. So for those hospitals that might not be so willing as as Community Health Network and Dan are to kind of be so very much engaged with the community, what can community groups do?
Well, I think that the IRS was pretty clear on their proposed rules that they really need to be engaging the community and getting input on the community level needs. So really identifying who their community is and going out to that community and asking them what are the unmet community health needs. But that also puts the onus back on the community to be paying attention to what the hospital is doing and to be asking the questions, sort of like what Dan was just talking about, of understanding their own data and finding that person at the hospital who they can start to build a relationship with. And whether that person's in the marketing department, in the external relations department, or in Dan's case, in the community benefit department. So doing some of that local organizing and finding ways to really help that hospital really find the community health needs that really they would like to see addressed beyond what the data may tell the hospital.
So just as a follow-up to that, so let's say a hospital completed its health needs assessment, and they have to do one every 3 years. And they didn't perhaps consider the community in the way that the community would have liked their thoughts and input to be received. Is there a comment process for which the community can add its thoughts that then the hospital would have to consider in 3 years' time when it does its next needs assessment? I know it's further down than we would like to, but is there a process for that kind of conversation to continue in the next assessment, which has to be done 3 years later?
Well, so there are places where the community can give those comments. So the community has to post its community health needs assessment report on their website and also make it available to those who request it. So that's the first opportunity, if you haven't been involved in the data collection, to see what data was collected and what the hospital heard for needs. And they're obligated to accept feedback from the community on what that data might mean and what it may not mean to the community. And then as the hospital determines the implementation strategies for the priorities they want to address, there's an opportunity for the community to get involved and partner. And so maybe the hospital may decide not to address all of the needs that it heard, but there might be opportunities for other partners, including universities and other anchors, to get involved in meeting some of those community health needs. So there are opportunities. It's really about getting that local community involved in organizing. And also know that Community Catalyst has a lot of tools and strategies that we can provide and talk about with community-based organizations and coalitions that they can use to help organize and build relationships with hospitals. So we have some great resources that we're glad to share, and we'll send some of those out with the resources at the end of the call, but they're also up on our website.
Great, Michele. Thanks for that. And so another question that has come in is, what are the best first steps for creating change to become a true anchor institution? And I'll let Dan tackle that one in a second, but I'll just, from my perspective, I think that there's one thing that we've seen is perhaps just having people in the different departments communicate with each other is a good first step. Oftentimes, there might be a person working on sustainability initiatives, or a person in the purchasing department, the community benefit person. They may rarely, if ever, interact, and it's about kind of creating a vision that can then be promoted higher up in the organization, and that allows for these different departments to kind of coordinate and work towards a shared set of goals. And the Anchor dashboard that I talked about earlier gives some of those indicators that a hospital can set as targets, so that they can have a plan towards visioning what it would mean to be a true anchor institution. But I'll let Dan also tackle that question. So go ahead, Dan.
Yeah, thanks, Dave. I really appreciate that. I think, as Michele has said too, is that it is really the responsibility of the hospital to reach out to the community, and I think the community can't shortchange that responsibility. To that end, however, I'm going to go back to my other soapbox as far as this is all new, and that, you know, we've had the privilege, if I'll say that, to have a community benefit law in place in Indiana for about 15 years. We were only one of, I think, a handful of states, maybe 15, that had that. So for a lot of states, this is really brand new. But the requirement for a community health needs assessment and every 3 years doesn't mean that that hospital shouldn't be collecting, and most of what they collect is secondary data, but really primary data is what they need, and that primary data comes from the community. In my particular situation, and what I think I would suggest to most people, and it's what you talked about, David, is go upstream. Where's the money? The money's at the CFO, but also it can be with somebody in purchasing. It can be someone who understands the economic impact of purchasing that the hospital has. You know, hospitals, again, as not-for-profit institutions, weren't founded to be anchors in the community, and it's with the globalization of businesses that hospitals have had to take that role on. In our particular situation, we had a major thoroughfare called Shadeland Avenue. Shadeland Avenue had probably 10 Fortune 500 companies, Fortune 100 companies littering all of Shadeland. And probably the most famous would be Western Electric, that invented or manufactured the telephone, of which we don't use anymore from one manufacturer. My point just being is that those are all gone, and the biggest employer in town is the hospital, or in that community is the hospital, and nobody's paradigm has shifted to include this responsibility in the community that had been covered by those other companies, and so the role the hospital played is minimal. So again, I just reiterate, yes, you can go to marketing, yes, you can go to your community benefit. I'm pretty rare as far as typically there's not someone in community benefit. It's usually marketing. And again, those folks sometimes can be a little overwhelmed with requests. So go the back door, finance, that kind of thing.
Great, Dan.
Sorry.
Thanks for that. No, thanks for that. I'm going to actually mute you because there's a little bit of feedback. But yes, thanks for that comment. And I'm going to merge two questions that we have here and then try and tackle both of them. One is with regard to equitable local and minority hiring. The question is, would this be for the hospitals to hire locally and with minorities, or to encourage other local businesses to hire locally? And the follow-up is, how would that look for hospitals? And the second question is with regard to experience working with the hospital anchor institutions in creating employer-assisted housing or land banking programs as community benefits. So to tackle the first question, I think it can be for both. It can be both for the hospitals to hire locally or to encourage other local businesses to hire locally. And the way this would be done, one example is the Evergreen Cooperatives in Cleveland, in which these are local businesses that meet the needs of some of the larger anchor institutions in the greater university circle. Cleveland Clinic and University Hospitals are the two health systems that are part of other anchor institutions in that area. And the businesses there try to meet the procurement needs, and they're set up in the surrounding communities that have high rates of poverty, extreme rates of unemployment, with the primary goal of targeting those groups of people to hire. And three businesses have been started up to date, one being a weatherization company that does solar panels for the anchor institutions. Another is a large urban greenhouse to meet the demand for local produce. And third is an industrial scale laundry that also serves local nursing homes in addition. And so that's one strategy for doing that. Trying to pull off a piece of the procurement to direct it locally, so that those businesses can then hire locally. In addition, the second way that could be done, though, some people will say that the health systems can't go out and specifically hire from a specific geography, but it would be unfair preferencing or whatnot, or other reasons. But what could be done is, and this could be definitely done for the community benefit, is providing resources to local workforce intermediaries to provide the skills and the resume training and those other kind of soft skills that many in lower income communities haven't had experience with or don't have access to learn about, so that they're on par with those that might have those skills already. And if they're in those occur in specific geographies, what you'll find is that then when they go for the interviews for the positions in the health systems, they tend to be the better candidates. And this is something we're also seeing in Cleveland with some of the training done at university hospitals. And so that's just two examples of how that can be done, and I'm sure there are plenty more ways to think about it that it could be creatively thought about. The other question with regard to employer-assisted housing, the issue there with community benefit is if it's done primarily for the institution, it can't count as community benefit. It has to be done, if Michele or Jessica want to comment on this, feel free. But my understanding is that if it's done primarily for the benefit of employees of the institution, it won't be counted as community benefit. However, if they did a housing program such as what Mayo Clinic did in about 10 years ago, in which they gave a significant portion, they gave nearly $7 million to the local community foundation to create a community land trust that was not just for their employees, but also for the larger community, then that would count as community benefit, because you are no longer just providing for your employees. And there are hospitals that are doing employer-assisted housing programs. They find that it's important that their employees now live closer. Both Henry Ford and Detroit Medical Center have employer-assisted housing programs, so do Cleveland Clinic and University Hospitals, and a number of other institutions are beginning to think about employer-assisted housing programs. But those would not count as community benefit. It would be if they did a broader affordable housing program, that those investments would be the ones that counted for community benefit. So I'll end there and we see if Michele or Jessica want to follow up on that.
Yeah, so housing could be counted as community benefit, but it really has to come through one of three ways. So it needs to be identified as a need in the community health needs assessment process. It can also come through partnership with a government organization, as well as could come as a request by the community. So in order for it to count as community benefit, it really needs to come through one of those avenues.
Great, thanks, Michele. So I'll ask this question to anyone who would like to answer it. Dan and Allison can take a first stab at it. But something that occurs to me is how do you keep the momentum going as you begin to institutionalize whether it's becoming an anchor or a community process for engaging an anchor? So what do you see as key elements of maintaining the momentum of a process as it builds towards something larger? So Allison, do you want to tackle that first?
Sure. I think for us, in our process, I mean, it's been ever evolving, but it helps that we have ongoing campaigns as well that are very immediate and very rooted in, and needs and demands and desires that folks have in the community. So that as we're kind of building this longer-term vision and sort of going through the more laborious process of building relationships that aren't going to yield like an immediate sort of payback, that there are campaigns like our economic justice campaigns around, redevelopment and the Kingsbridge Armory and beyond, or a campaign that I'm currently working on, actually directly related to a hospital in our community where the labor and delivery services have been eliminated, where action is kind of what feeds and generates more and more energy for folks. Yet at the same time, people are realizing that we've been organizing and using these particular strategies around direct action for 40 years, and they've yielded a lot of tremendous victories. But at the same time, our people are getting poorer. The wealth disparity is growing, and our rents are getting higher. So there is, I think, an intimate sense that we have to seek out a different approach as well, and how we engage with our web of community institutions if we want to really build a more sustainable livelihood for folks and really get at like root causes. So I think the interaction of those two really helps.
Great, Allison. Thank you.
Yeah,
Dan, you want to chime in really quickly?
Yeah, I just think that she's pretty much covered it. The other thing, though, that I would have to add is that, how do you keep the momentum? What's momentum? Are those organizations living up to the hospital's expectations, or is the hospital living up to their expectations? And it's the latter, I would say, that can keep the momentum going. The former often stalls it because it's the hospital's solution to the issue, not the community's.
Great. So thanks everyone for joining us today. We'll make sure to, if you don't feel like we answered your question, please feel free to follow up with us, and we can try and reach out also if we didn't successfully do that. Also, you may have noticed that Yorman was unable to join us, and so for those who pointed out, unfortunately, it wasn't able to work out. But if you have specific questions about BCDI, the Bronx Cooperative Development Initiative, we can definitely send you information about that afterwards. So thanks everyone, and look out for future emails about the follow-ups to this webinar. Thanks. Bye.